everyone, and welcome back to the hashtag See Arthritis event as part of the Canadian Rheumatology Association and Arthritis Health Professions Association annual scientific meeting held in Calgary. My name is Cheryl Koehn. I'm with Arthritis Consumer Experts. We host the event on Arthritis Broadcast Network, which is what you're viewing on. So welcome to the show and welcome Dr. Tom Appleton to the studio.
Thanks, Cheryl. I never forget who you are, though.
I only forget who I am. It's a sign of age and too much going on in this little head of mine. It's always great to have you in the studio and to chat. As we were speaking before we went on air, Dr. Appleton, you're one of our crowd favorites because one, the topic affects a lot of people. That's osteoarthritis, and you speak in very plain language, which we always appreciate. So let me first introduce you to the audience very quickly before we dive in. So Dr. Appleton is passionate about rheumatology research. So rheumatology, just think arthritis, communication and clinical care. He is the Division of Rheumatology at Head of Rheumatology at St. Joseph's Health Centre in London and Western Ontario. Western University in London, pardon me. As a clinician scientist, Dr. Appleton's research focuses on the resolution of inflammation, pain, and joint damage in osteoarthritis and inflammatory arthritis. Dr. Appleton is the past director of the Ontario Rheumatology Association, or fondly known as the ORA, and past chair of the Canadian Rheumatology Association, which is the National Association for Rheumatologists. Dr. Appleton now serves as an advisor to the Arthritis Society Canada, one of our very important partners in the community, and chairs the Ontario Rheumatology Association Informatics Committee. So it seems to me I'm going to diagnose you with volunteerism disease, Dr. Appleton. You've got a severe case of it.
It's great to be involved in lots of
Yeah.
meaningful things, and it's nice to be able to contribute.
Yeah, well, it's actually not an overly large community, the rheumatology community, when you boil right down to it. And I have found over the years it to be so collegial, friendly, fun. I think those are some of the key words that patient organizations would use to describe the work that you've been doing with the people you've been doing it with. So, Dr. Appleton, let's just dive right in. The meeting was chock-a-block full of new science. You yourself focus on osteoarthritis, though I know also inflammatory arthritis. But for our audience, just let's start at the very beginning, which is, tell us what osteoarthritis is or isn't. Remember, the public thinks osteoarthritis is one thing, and it may not be necessarily entirely true. And talk to us maybe about what the risk factors are that increase a person's chance of getting osteoarthritis. And so we'll start there as laying the groundwork for our conversation.
Sure. So osteoarthritis is it's really the emperor of all of the arthritides, and it's that in the way that it's the most common form of arthritis in the world, but also in that it seems to be one of the most difficult to treat. And I think that comes back to our just really ineffective understanding of how this disease comes to be. And that's part of what drew me to this a few decades ago, trying to get into the research field. And this really interesting problem of how we try to understand this disease continues to perplex us to this day. But I think we understand much better now, fortunately, than we did a couple of decades ago. And we now really understand osteoarthritis to be your body's way of trying to repair and maintain the health of our joints, and that ultimately end up failing, and then we get pain with activity and all the rest.
It's very interesting. The usual answer you're given by a member of the public, if you say, what is, let's say, arthritis, they say, well, my grandmother had it, so I'm going to get it. So we know that is not the case. I mean, she may have had it and you may get it, but not because your grandmother had it. And it's not a disease of the elderly. Tell us a little bit about some of the research that you've been doing, Dr. Appleton, let's say over this last decade when you've really immersed yourself in this scientific community?
Yeah. So, I mean, I think we commonly hear people refer to arthritis in one of two ways. One being that, oh, it's just natural aging, and that is absolutely not the case. Natural aging for 80% of us is not getting arthritis.
Right.
So, natural aging can't possibly be the issue. And the second is people refer to it as more of a wear and tear kind of disease, which I absolutely understand why that would kind of come to mind, especially because most of the time arthritis hurts more when you move. But it isn't really an effective way of thinking about it because our bodies are designed to maintain and heal our tissues and our organs and our joint organs, which is what happening with arthritis. Is really where things are going wrong. So it's not things wearing down. It's the inability to maintain their health over time. So it takes a little bit of thinking, but I think we've definitely gotten to a point now where people understand, yeah, I need to move. Movement is actually good for our joints, and we should be continuing to focus on those things. And for the others that isn't enough, well, we've got a lot of research that we're working on.
Yeah, the I know that you're familiar with Dr. Jackie Whitaker's work in sports, especially in youth sport, and the role that injury plays in osteoarthritis or development of osteoarthritis. And again, the lay public thinks, well, I heard it playing football, so I'm going to get it. But it's not actually that simple. And I've heard you give talks on this before. Can you talk about just really briefly about injury and lesions and what happens, that it's not just as simple, oh, I sprained it, so I'm going to get arthritis. So maybe I'll leave it there and let you answer.
Well, I absolutely love the work that Dr. Whitaker is doing, and she's based in British Columbia. Part of our Canadian research fabric, and so we're really, really pleased to have her contributing to this cause. Her focus in particular is trying to prevent injuries in young people, and I think that's just such an important thing for us to be doing for many reasons, including the fact that it increases the risk of developing arthritis. What's I think really important for a lot of us to know, though, is if you have an injury, really at any age, certainly young adults, the risk of developing arthritis is very high within the next
Yeah.
5 to 10 years. About 50% will develop it. So it really isn't just, oh, down the road. It's like a here and now kind of thing. If you have a lot of damage to your joint tissues, I mean, your body has to try to repair that. And if you're not able to fully repair it, you're going to end up with chronic symptoms. So, how you rehab it, how you go through that process of trying to get the joint to heal afterward is actually really important. And getting the care soon after an injury and getting the advice so you can slowly get back to normal activities is really, really key to that healing process.
And talk to us a little bit about sort of at the cellular level, what is happening? What is happening in osteoarthritis?
It's really, really interesting. So we know at the cornerstone of our healing process, the immune system is involved right from the very beginning. And as rheumatologists, we're very focused on the role that the immune system plays in all of our diseases. In many cases, like rheumatoid arthritis, which is our best understood autoimmune arthritis, the immune system is a sort of independently attacking us. So that's not what's happening in osteoarthritis, but the immune system is activated right from the very beginning. And its job is really to try to help heal and resolve inflammation as we've had an injury or we've had some other causes for the arthritis that's been triggered. And for most of us, most of the time, it actually works extremely well. And what we're trying to understand in the lab is how the immune cells that get recruited to joints either after an injury or chronically during disease are either helping us or working against us if that inflammation doesn't ultimately end up resolving. So in the end, it all comes back to inflammation, but the type of inflammation that's involved in osteoarthritis is different than the autoimmune inflammation that we see in rheumatoid and other autoimmune conditions.
But the inflammatory bad guys hang around and do things that they're not supposed to do, I guess, ultimately.
That's right. That's
Yeah.
right. Yeah, exactly. So we're trying to figure out what they're doing and how to inhibit that but also really get to the underlying cause. Why doesn't inflammation resolve the way that it should? And if we can figure that out, and it's different from person to person, then we can often get it to turn off, and then the body's normal healing processes take over.
Right, which would, I guess, would it be primary prevention then at that point or secondary
That
prevention?
would that would be secondary. So if you've got
Okay,
somebody who's already got arthritis symptoms, they've got some sign of inflammation, which we can measure with imaging tests or other biochemical tests, then you've already kicked off the process. And the question becomes, how can you prevent that from progressing?
right.
And ideally, we get it to turn off and things stay in remission, so to speak.
And are we any closer to knowing about primary prevention?
Yeah, I mean that really cuts back to a couple of things, which I think one you already mentioned, Dr. Whitaker's work, preventing those initial injuries or
Right.
inciting injuries. I think is really key from a primary prevention standpoint. But also, people who have, and there's a lot of people in society now who have metabolic disease, which is probably an even bigger contributor to the overall burden of arthritis that we see in society. That trying to get at the root causes of metabolic disease, whether that's diabetes or high blood pressure or cholesterol or obesity, all of those metabolic conditions really increase the risk of developing arthritis. And so if we can get at the underlying contributions to those risk factors, just in the same way we can lower the incidence of heart disease, we can also lower the incidence of joint disease.
Wow, that's fascinating. I just see all this bad stuff mixing together and
Yeah.
coming out with arthritis. Yeah. When you think about the advances, so the knowledge you've just shared over the last few minutes, Dr. Appleton, how does that influence the way you actually practice today in your clinic? What do you say to people? I mean, you're obviously seeing, well, I'm assuming you're seeing people who already have joint complaints, joint pain, joint disability. How are you incorporating these new findings with these people, and how are you better helping, I guess, those that are presenting earlier than perhaps they might have a decade ago? Maybe they're not, I don't know.
I think there's a few things that we need to do. I mean, in the clinic, you're absolutely right. People are coming to us because they've already developed a problem, and that makes sense. So in that setting, what we're really trying to understand is, first of all, how far along is this?
Right.
What stage of disease is there already achieved? And is that something that we need to, that's already end stage, we need to move along to a surgical kind of management? Fortunately, that's not often the case. It does happen, but it's not often the case. There usually are other things that can be done, and hopefully never end up needing to get to that sort of, sort of severe intervention for severe damage. But then we're really looking at risk factors. Are you somebody who's at risk of having this progress in the short to medium to longer term? And if so, what are the risk factors that are in place and what can we do to modify those? And oftentimes there are multiple things that can be done, but I'll just group them broadly into
Sure.
biomechanical problems or risk factors and metabolic factors. And addressing all of those, not just one at a time, but really kind of looking at this person, their particular risk factor mix, and what can be prioritized now, today, that we can actually start modifying. That really makes the biggest difference for people and their risk going forward. And fortunately, there are some people who will actually get better and will respond to that and actually not have any further progression. And that's really satisfying. We're able to identify that. For those who really are progressing, there are still other options and things that we can bring into the mix. But I would love, as you've alluded to get to the point where we can say, hey, you know what? You don't yet have arthritis, but these are some of the things that we know could happen and they're risk factors for you, be those biomechanical factors, be those metabolic factors. And let's prioritize those in a primary care setting or even in a community-based setting where we know we've got excellent collaborators in the arthritis allied health provider community who can really start to dig into some of these issues with people and provide that education, that motivation, and the opportunity to try to change their long-term outcomes.
That is super fascinating. When you think about the people that you maybe can get to earlier, that you can see earlier and make those changes, tackle the whole problem all at once and early. Are there characteristics of the people sitting in front of you in your office that spell you're going to do better perhaps than another? Like what things do I need to be good at to work with you to get a good outcome?
I really love that question, Cheryl. I mean, it is a partnership at the end of the day.
Right.
And most of us are in a good way are really in charge of our own destiny, right? Sometimes you can't change the things that happen to you, but a lot of things a lot of things you can do something about. And I think finding that motivation within us is a big part of it. So having a close partnership with my patients is a big part of what we do. Because at the end of the day, I can make these suggestions, but ultimately it's whether we're actually going to put it into practice or not.
Yeah, the
So
rubber hits the road with the individual for sure.
yeah, for sure. So I mean, like I say, it's a joint partnership kind of thing. It's not one or the other. We all have a responsibility in this, but I think things work the best in the long term when both parties are really invested in that good outcome.
Yeah, and have trust probably in each other that I believe you know what you're doing. I trust you. And when you give me that advice, I hope you trust I'm going to go away and implement. The one thing is, you'll know when I don't implement because when I come into your clinic, you'll know that I haven't really held up my end of the bargain. So,
That's okay though. That's okay. I mean,
yeah,
we're all human and we all have
yeah.
busy lives and there are things that are going on. And so we just reset and take a look at it and find another way that's going to be easier to implement.
Oh, I love that. Okay, we're going to just kind of end our discussion here, Dr. Appleton, on the informatics side. So, I mentioned in your introduction that you are chairing the Ontario Rheumatology Association Informatics Committee. So, I immediately think data, registries, digital platforms. Explain to the audience what it is your group, your team in this committee is working on.
Yeah, so you definitely hit on a lot of the key
Okay,
buzz terms there. The Ontario Rheumatology Association has long been really interested in outcomes. What our vision is to be able to achieve the best outcomes possible for people with rheumatologic diseases in Ontario, but obviously we're very much in a Canadian context. So, in order to do that, we need to be able to measure things. We need to be able to reflect on our practices, find where there are opportunities for improvement, make those improvements, and then be able to assess and measure that there has been a change as a result of those interventions. And so that brings us back to technology. I mean, our practices are very busy. There are lots of complexities. Healthcare is quite fragmented in terms of how it's delivered, where and when, and different mechanisms that are in place. And so having a way of standardizing that information becomes really essential to being able to understand how well we're doing with delivering practice or delivering care in our practices. So that's where the informatics committee started, and we have developed digital health solutions that are meant to provide rheumatologists with rheumatology specific measurements to be able to do just that, reflect on our practice, see how we're doing, and make those changes over time. Now, over the years, that has really evolved with the advent of new technologies, and everybody is talking about AI these days.
right.
Artificial intelligence is everywhere. And we're absolutely leveraging those opportunities as well. So, trying to bring solutions that are not just for healthcare, but really are tailored to rheumatologists' needs, and to bring that all together. And this is the most important part, integrated in a way that the information flows from one part of the patient's journey through to wherever we're going with that journey. And it all connects and provides that sort of real time, in the moment feedback. And I think that's how we start to really make improvements in the quality of care.
Yeah, super exciting. You're right. The annual meeting had a lot of buzz around AI. One of the keynote speakers talked about AI and tried to help offer some lessons learned from other areas for rheumatologists who were present at the meeting. I know that the Canadian Rheumatology Association has an AI scribing um, project going on. I gather the ORA is probably very, I mean, you're obviously in tune with it. How might it fit in with the work then that you're doing in your own province?
Yeah,
Maybe
I
it
think
doesn't, I don't know, but I would assume there's probably some overlap.
Well, I think you said it quite rightly earlier when you said this is a very small community when it gets right down to it. The
Yeah.
arthritis community in Canada is a very close-knit community, and so absolutely the LRA and the CRA are very much aligned in our goals to try to bring the best quality care possible to Canadians with rheumatologic disease, not just in Ontario, of course, and to help rheumatologists be able to do that. I firmly believe, and I think the ORA's approach is really that the best quality care is one where we can actually communicate. The physician, the patient, or the healthcare provider and the patient are able to have eye contact, to listen to each other, to really focus on that exchange of information between each other, and not have the technology getting in the way. And I think that's where the opportunities and the excitement around AI really sits because it can help to take away some of that more burdensome stuff that takes the attention away from the patient and onto the technology, have it more in the background, carry out those tasks, and then we can get back to doing what we really want to do, which is have a meaningful conversation and relationship where we engage in shared decision making.
Yeah, I absolutely love that. And we do a lot of survey work across the country and we offer lots of chances for people to offer open-ended comments. And when we have surveyed people about technology in particular, this was early days, so not necessarily AI, but certainly transcribing devices, them being used in real time in clinic. And, we have had comments that were like, well, my doctor's face was down in his dictaphone or was looking at his screen and not at me. So I think what you're suggesting, Dr. Appleton, is totally on track with what patients are looking for. We are looking for that face-to-face, eye-to-eye meaningful contact. Meanwhile, the AI is there in the background doing its work and hopefully supporting that in a way that then can be shared across the care team. I think that's kind of holistically speaking and this is my own little world inside my own little head, what's going to happen with AI. I think there's lots of things around, security, some of the standard things we've been talking about for a long time with digital technologies. How is it going to be secure? Is it going to be accurate? And how do people like myself who live with disease and come into your clinic, how do we feel about you're using AI? It's still early days. But I'm so excited that the rheumatology community it's right on it. You guys are working hard at not just the clinical puzzles, the basic science puzzles, but you're trying to figure out the healthcare puzzles while you do it at the same time. So, and providing great care for people like me. So, just want to thank you so much. Is there anything else you want to share? Any last sort of thoughts or pearls with the audience before we let you go on about your busy day?
I think that's a really nice summary, Cheryl. And I think the only thing I would have to add is thank you so much for providing this platform and this opportunity to reach out to the arthritis community. The arthritis community is not just the physicians and providers, it's also the patients who we work with all the time. And so having these opportunities to connect, I think is really important. And that's how we'll have the next great round of ideas.
Yeah, exactly. Well, thank you so much, Dr. Appleton. We're very appreciative of your time and your expertise, and we wish you well in the work that you're doing now and in the future, because it's going to help people with arthritis. It already has, and that's why we're all in it.
Thank you, Cheryl.
Thank you. Thanks, audience, for tuning in, and check back in, catch our next episode. Bye for now.